my name is Sydney Thomas, and this is my presentation on small bowel obstructions. I chose to complete this project on small bowel obstructions because I have seen it over and over again in the clinical field. This project is focused around a patient that I had during this clinical rotation. The patient was a 38-year-old female with no known drug allergies. The patient came in through the emergency department with complaints of abdominal pain, nausea, and vomiting. According to some research articles, small bowel obstructions are responsible for up to 51% of all emergency laparotomies. In addition, small bowel obstructions also make up 80% of all general surgery emergency admissions, morbidity, deaths, and healthcare expenditures in the United States. Postoperative adhesions are the most common cause of small bowel obstructions. They account for up to 60% of all cases. Next, I have several articles that were used to help me formulate my nursing care algorithm. This article emphasizes the importance of diagnosis of a small bowel obstruction as early as possible. It includes making sure that an accurate history and physical exam are obtained. It is essential so that treatment can begin as early as possible. This article aims to examine the importance of bowel sound auscultation in the presence of a small bowel obstruction. It elaborates on how individuals should listen to each quadrant thoroughly during a physical exam. This article discusses how individuals that have had a history of abdominal surgeries are at an increased risk for developing a small bowel obstruction due to adhesions. This article discusses the use of conservative measures to take in the instance of a small bowel obstruction. These conservative measures include making the patient NPO, or nothing by mouth, inserting a nasogastric tube for decompression, and ambulation. This article discusses how the duration of stay tends to decrease when early ambulation is enforced. This article concludes that although sometimes small bowel obstructions can be resolved through conservative measures, there is more satisfaction from patients when there is surgical involvement. So this is my plan of care that I came up with for my patient. It all starts with assessment. So I came up with 3 key assessments that I would like to focus on. These 3 were elimination, fluid and electrolytes, and pain. My priority assessment would be pain. I chose this because the patient is not going to be willing to participate in their care if their pain is not under control. My next assessment would be elimination, making sure to listen to their bowel sounds to see if any are present, palpating the abdomen for distension, and noting any tenderness. It is also important to ask when their last bowel movement was. I would also like to look at their fluid and electrolytes because these patients are at risk for dehydration. My goal for my patient was for her to ambulate in the hallway 3 times during my shift. I chose this because ambulation is incredibly important and is sometimes overlooked as an effective intervention. While encouraging ambulation, I will provide pain measures so that the patient is more comfortable. The outcome from the shift was my patient began to pass flatus. In addition, by the end of the shift, bowel sounds were starting to become present. Here is the algorithm that I came up with for small bowel obstructions. Let's start at the beginning. A patient presents to the emergency department with abdominal pain, nausea, and vomiting. The first thing to do is an assessment. Assess pain. Ask them when it started, where it's located in the abdomen, how long has it lasted, what have they done to help their pain, and what seems to make the pain worse. Then, listen to their abdomen for bowel sounds. It is also important to palpate for distension and pay attention to any tender areas. Make sure to get an accurate history, particularly paying attention to any history of abdominal surgeries. It is also important to obtain a set of labs, including a complete blood count to look for an elevated white blood cell count and potential markers of dehydration. The patient says that she had an appendectomy when she was 3 years old, so there is a potential that her abdominal pain could be caused by adhesions, even though her surgery was 35 years ago. Even if you know for sure that this could be caused by adhesions, a CT scan with water-soluble contrast should be completed. The impression from the scan should indicate if there is a need for emergency surgery or not. Some things that might lead to emergency surgery include strangulation, bowel ischemia, and peritonitis. If there are no signs that emergency surgery is needed, conservative treatment is the route to go. Conservative treatment includes making the patient NPO, or nothing by mouth, inserting a nasogastric tube for decompression, and hooking it up to suction. Another big thing that helps in conservative treatment is ambulation. Ambulation helps stimulate bowel motility. The next thing that should be done is see if there is any contrast left in the colon after 24 to 36 hours. If there is, conservative treatment can continue. If there is not any contrast in the colon, surgical exploration is needed. When conservative treatment continues, it is important to document the amount of output from the nasogastric tube over a period of time. Theoretically, the output should be less and less as time goes on. However, if there is still a high amount of output, that leads to a failure of conservative treatment and surgery is needed. In conclusion, small bowel obstructions are a common occurrence everywhere across the United States. Individuals that are at a high risk for developing a small bowel obstruction are those with a history of abdominal surgery or Crohn's disease. A small bowel obstruction is diagnosed through the use of a computed tomography scan or a CT scan. Treatment can be classified as conservative or non-conservative. Conservative measures include making the patient NPO, inserting a nasogastric tube to suction, chewing gum, and enforcing and encouraging ambulation. Non-conservative measures require the assistance of a surgical team. Finally, here is a list of all the resources that I utilized to create this presentation. And that brings my presentation to an end. Thank you for taking the time to listen, and I hope it was educational.